CAPRI include, as you mentioned, both treatment naive and previously treated patients. So in your practice, which of those groups stands to benefit most from a sustained delivery option, and why does that mix matter for interpreting the data to come?
Yeah. Well, I think that initially, if and when this becomes available, I think that we have a whole backlog of patients who have already been treated who haven't achieved 100% success with whatever we define as success. They still have some edema. They're getting frequent injections, and it's becoming difficult for them to come in. Or they're the patient that gets frequent injections and then disappears for a while. So I think that we have a backlog of these patients that are previously treated. So initially, these patients are going to benefit the most from it. And it's great that the trial looked at these patients as well, because we can then say that, it'll be approved for a wider range of indications. And I think that the community will be more comfortable that this has been used in previously treated patients. Second of all, I do think that the naive patients, it'll become sort of the thought process will change. I mean, we may start with an anti-VEGF injection, one or two or three. Of course, in the trial, the patients, even in the EYP-1901 arm, are getting three intravitreal aflibercept injections. So they're sort of previously treated anyhow. We want to make sure they have a response to the therapy. And then we're going to add this on top, I think, as was done in the trial over the 6-month period. Then we'll hopefully, based on how well the trial reduces the need for supplemental injections, it'll reduce that need for patients. And I think the other thing to think about this is that really the nice thing to have in these patients will be an underlying drug delivery that lasts 6 months. And actually, there may still be some drug delivery 6 to 9 months in some cases. So again, remember that if we have this underlying drug delivery, and I think back to the port delivery system, which is refilled every 6 or 9 months, depending, and there's this underlying suppression. This seems to have a very positive effect for the diabetic disease in the eye, as well as the diabetic macular edema. And God forbid if the patient, can't make it back in for a month or two or three, it's unlikely they're going to have a real serious degradation in their disease process or their vision because of this suppression. So it gives us a wiggle room, I think, with our treatment management in these patients.
EYP-1901 is a TKI that targets VEGF and PDGF receptors, plus IL-6, JAK1 inflammatory signaling.
Yeah.
So this is a different approach than the anti-VEGF biologics currently used for treatment.
Yeah.
How much does the multi-mechanism rationale factor into your enthusiasm for the program versus the 6-month dosing interval itself, or does it?
No, I think it does, but we have to separate what we know versus what we don't know in theory. I think that in theory, first of all, blocking all three of the VEGF receptors may be very helpful for us, blocking them downstream from the tyrosine kinase inhibition. I think the PDGF makes sense in diabetic patients, probably even more than in AMD patients, because this is going to affect the pericytes in the eye, which are, of course, very important for vasculature in the retina. So, from a theory at least, I think it makes some sense. And then the IL-6, JAK-STAT pathway, again, is pretty intriguing from the standpoint, again, that, in diabetic disease, there is inflammation that's playing a role. The IL-6 upregulation can cause increased permeability that goes beyond the anti-VEGF pathway in a separate pathway. So blocking this makes a lot of sense. And, I think that there has been some modeling that's been done now using vorolanib and looking how it does inhibit IL-6 in preclinical work and in permeability models. That's pretty intriguing. But again, separating this benefit out may be difficult in the clinical trial, may require some additional work. And there are some other groups that are looking at other IL-6 inhibition in co-formulation, bispecific molecules that are anti-VEGF as well as IL-6, and comparing that with straightforward anti-VEGF. And so, if we see a definite benefit in the diabetic patients compared to just anti-VEGF alone, it'll sort of lead more credence to the fact that blocking these other things, PDGF and IL-6, are important in the clinical setting. Again, a lot of theory, some pretty good preclinical work, but how this actually benefits the patients and their diabetic edema or diabetic retinopathy will have to figure this out over time.
So with enrollment complete, what are the next real inflection points investigators in the field should be watching between now and the release of the top line data in Q4 of 2027?
Yeah, I think a couple of things. First of all, this molecule, this EYP-1901, is going to be reading out for the neovascular AMD trials through Lucia and Lugano trial much sooner. So we can get some sort of signal of what's happening with EYP-1901. Certainly from a safety standpoint, we're going to learn a lot more. And so if the drug looks very safe, we're not having any problems with it in the neovascular AMD trials, I think that's going to make us feel better about what's happening in the diabetic case as well. And efficacy as well. Certainly, if we see that the drug is maintaining the retinal anatomy, even though it's a different disease process, neovascular AMD, it's maintaining it over the 6-month period, we're going to be more comfortable that the drug actually is doing what it says it does and for that period of time. So I think that'll be exciting as well. So that'd be number one. Certainly, there are going to be other trials that are coming out looking at using different agents, TKIs as well, but won't be reading out before this one. So we'll have to sort of wait on that. I think again, if the study keeps going, the DSMC meets every 6 months or so. I don't know exactly what they meet, but if there's no safety signal, the study will continue over time, and so it'd be good to see how that's going as well. So, yeah, I think that we're going to see it. We're going to learn a lot more looking at the Lugano and Lucia trials that'll actually show us some, and it'll confirm our assumptions for patients with DME. But again, DME is a different disease. Some of these benefits of this vorolanib molecule may be better for a diabetic situation than it would be even for a neovascular AMD situation. So we're not going to know entirely, but making that comparison. But I think it'll be reassuring.
So we've kind of touched on the wet AMD phase 3 program, which is the Lugana and Lucia trials. So those read out starting this month ahead of DME. We talked about it a bit already, but how much should the retina community see the wet AMD results as a signal for what to expect in DME? And where does that analogy kind of break down?
Yeah, we have discussed it. I guess, again, I think that it'll give us a lot more safety information. How well is this drug tolerated from a safety standpoint? Is there inflammation? Are there other tolerability issues that come up, in breakdown of the drug over time? Do patients tolerate these injections the same as they do intravitreal injections? So we'll learn a lot about that. We'll be comforted again by the efficacy. Certainly, if the drug seems to be as durable as it has looked in the earlier phase trials, I think that'll be very reassuring, and the reduction in the treatment burden. Whether or not that'd be the same in a diabetic patient or a diabetic macular edema patient, again, it's a different disease process. So I think the efficacy standpoint of things will be a little bit more difficult to be comforted by based on the Lucia and Lugano trial results. But again, I think certainly it'll be exciting to see these results very soon.